Good afternoon and very welcome to this afternoon session for primary total hip replacement. What can go wrong? Joining me on the days are Mr. Sanjeev Agrawal, consultant orthopedic surgeon at the Landock and University Hospital of Wales. And on my right here, Mr. Sheval Dalal, one of our senior trainees. Joining me on the panel internationally, we have got Jonathan Howell, consultant orthopedic surgeon at the Princess Elizabeth Orthopedic Hospital in Exeter. Jonathan trained in London, followed by a stint in Royal Air Force, and his orthopedic training was in the Southwest, Vancouver, and then Exeter. Jonathan has been the president of British Hip Society and is the executive member since 2011. Joining me from India is Mr. Vijay Bose. Vijay is a senior orthopedic consultant and joint director at the Asian Joint Reconstruction Institute at the SRM, Institute of Medical Sciences, Chennai. Vijay had done his higher orthopedic training in the UK, gaining his FRCS Orth and MCH Orth from Liverpool, and he is also been the vice chair of the Indian Arthroplasty Association. Joining me from further north in the UK is Ananda Nanu. Ananda is an orthopedic consultant at Sunderland. He trained in the Northeast and Liverpool, getting his MCH Orth and FRCS Orth. He leads the pelvic and acetabular reconstruction service in Sunderland. And he is one of the few people across the world who is still doing hip resurfacing. He's widely published and has a chapter in Oxford textbook of orthopedics. He was still recently the president of British Orthopedic Association. So welcome all. We have a wonderful panel, and I'm sure we'll have a very stimulating discussion this afternoon. What can go wrong? So what we thought was we'll find out from the trainee's perspective what they worry about the most, what can go wrong. And we have a trainee here, Mr. Dalal, who will tell us a couple of worries that he has when he's doing a hip replacement. Over to you, Sheval.
Thank you, Mr. Singhal, and thank you, Bias, for this wonderful opportunity. I'll start off with a couple of questions which I'm always concerned about while doing a total hip replacement as somebody who's starting out. One is I'd like to get an opinion from the faculty while reaming the acetabulum with the first reamer and going medially. I've always found it a bit difficult to assess as to how medial you need to go right down to the floor and what are your landmarks and any guidance about that. And the second one is with regards to the limb length discrepancy, which we need to assess intraoperatively. There's a bit of eyeballing when we assess the limb length after doing a total hip replacement. And I'd again like to get the advice of the faculty and our expert panel here as to how and what are the tips and tricks they can give to assess accurately the limb length assessment intraoperatively.
Thank you, Sheval. So Jonathan here would say this is all down to proper preoperative planning. Over to you, Jonathan, because I know you're a great proponent of preoperative planning and you'll share your experience with us. Thank you.
Yeah, Chef, thanks very much indeed. And thank you for having me here. Hopefully my slides will come up in just a sec. The session's all about what can go wrong with hip replacement. And I think what you've just said is absolutely right. A lot of the problems with hip replacement can be avoided if we actually plan the operation before we get into the operation theatre. And I hope to address those two points during these next few slides. So I am very keen on templating and planning, as you say. Here's my disclosures. I'm a consultant for Stryker on the Exeter hip replacement. I'm going to avoid talking about any prostheses during this presentation. So really, preoperative planning for me can be done in 6 basic steps, and I follow the same steps whether I'm doing this for a simple primary, a complex primary, or one with a robot. The first step is really to assess the x-rays. They must be recent. For me, that means within 3 months. An AP pelvis for hips, showing the femur more than the spine. I use a marker to judge the magnification of the x-ray as outlined by that white arrow. And the legs should be internally rotated 15 degrees to get the valgus right and to get the offset. And this x-ray really shows the difference if you don't. On the left-hand side there, these are the same hip. On the left-hand side there, the externally rotated x-ray, it looks more valgus and the offset is foreshortened. On the right, it's properly internally rotated. You see the true offset and the true varus neck angle. So the second thing really is to look for bone deficiency and bone excess. I find a horizontal line placed across an identifiable landmark like the teardrop very useful, because then you can draw a parallel line across the roof of the normal acetabulum to show any defect on the side that you're going to do, where that defect is and whether or not it is contained. And in terms of bone excess, well, of course, we often have osteophytes around the hip, but other things can also crop up. This person with bilateral shelves has got an anterior bony excess that must be dealt with during the surgery if you're to avoid impingement and dislocation. We've just heard that leg length is a concern, and it absolutely is. It's a key reason why people get sued after hip replacement. So leg length is really key to get right. Again, the horizontal line, either across the teardrops or the inferior aspect of the obturator foramen is a constant landmark, and we can measure down to the lesser trochanter, same point, to assess the true preoperative leg length difference. And then we can try to correct that during the operation. The fourth step is to establish the center of rotation of the acetabulum. On the left-hand side is how I do it with a cemented hip. And the three landmarks I really look for are the teardrop here, the bottom end of the cup being down at the teardrop, the ilioischial line, the reamer here in the dotted line should be adjacent to the ilioischial line. And then the superlateral margin of the hip will give us the sort of correct size. So this is a 54 cup on the left side. On the right side is how I plan an uncemented cup. You can see I've just left that uncemented cup just off the medial floor, and perhaps we can come into that in discussion because it goes back to what your guest just said there about how to ream medially. I'll come on to that perhaps in discussion. So having got the acetabulum in the right spot, we can now measure the femoral offset and size. You can see here, this medial dot here, that's the true center of the acetabulum, and that's what we've got to match with the femur. Now this femur has an offset of 37.5. It's short here of offset, but this one here is 44 offset. And you can see that the femoral offset, the center of rotation, is overlapping the acetabulum. And so that's the correct offset for this patient. Sometimes this is best measured by just looking at the femoral template, putting that down the center of the femur there, and then looking at the femoral head and putting that concentrically within the native femoral head. And that will really give you a very good guide to the offset that you need. In terms of stem size, I use cemented stems. I look for where the reamer would be. You can see on this size 3 here, that reamer would be in the cortical bone. That's too large. Here, it's too small. So I'll go between these two, a size 2 probably for that. And then really importantly for leg length, measure how deep your stem is to be inserted. And I measure this line from the tip of the greater trochanter down to the shoulder. And really the key concept here is control of leg length. If you get the cup in the right place, control of leg length is entirely dependent on where you put the femoral component. If you want to shorten the leg length, you put it in further. If you want to lengthen the leg, you put it out leave it out further. So intraoperatively, we would measure the depth of insertion here of the rasp, measure that on the rasp handle, and then insert that rasp to be opposite the greater trochanter. And you know that you've got the leg length right if you've put the cup in the right place. Here's a couple of examples of how to get it right. Very valgus hip and a dysplastic man of 45 years of age with a failed left hip. So I'm going to leave the neck cut long. I'm going to plan to leave the stem further out. And you can see by doing that, you restore the leg length to what it should be, but you've thought about it before the operation, and so you get the leg length right. Here's an opposite thing, a very varus hip. Here we've got a hip that starts the same length on the other side. We're going to do the right hip. In this case, we're planning to put this, the rasp in 26 mils. You've done that in the operation, and you've got the leg length right. So it's purely leg length is controlled by how deep or otherwise you leave the stem. And this technique has been assessed by researchers in Scotland, and they found the lowest rate of leg length discrepancy in the world literature of 1.3 millimeters average post-op. So to summarize, I think planning is part of the procedure, absolutely integral to it. I think whether you're using acetates, digital or robotic techniques, you can follow 6 essential steps and you'll get your planning right pretty much every time. I'll leave it there and return for discussion.
Thank you, Jonathan. You have illustrated beautifully why the trainee should all get into the habit of preoperative planning. So to come back to Shaival's original question of preventing a acetabular flow perforation, would you give a tip to him about preventing that? And I'll then follow the same question from Vijay and Sanjeev.
Absolutely. I think it starts with whether you're going to do an uncemented cup or a cemented cup. I think it also starts with preoperative planning. Like I said, the bone deficiency, bone excess. So you're looking for that osteophyte on the medial floor. How deep do I expect it to be? You know that there's always fat in the fovea there. That's your first sign that you're getting close to the true medial wall. And then the medial wall should be identifiable once you remove that fat. With a cemented cup, I tend to ream down to that medial wall, then put bone graft on that medial wall, then cement it in the cup. With an uncemented cup, I tend not to go all the way to the medial wall in every case. It really depends on the preoperative planning and where I want to put the uncemented shell. It is in my view, it's a technical mistake to over-medialize an uncemented shell. I've probably been doing it for years, and it was only when I got into robotic surgery that I realized that was actually reducing the total offset of the hip. So I think the avoiding reaming out medially starts, I don't want to sound like a stuck record here, but it starts with planning and understanding what you're going to try and achieve during the operation before you even pick up the knife.
Thank you, Jonathan. Before I go on to Vijay, perhaps I can come to Sanjeev. How do you prevent a medial blowout?
Well, the views expressed by Mr. Howells are absolutely spot on, and I think preoperative planning is the key to avoiding any such problems during surgery. So before I start, and this happened when I was a fellow in the US, we were not allowed to operate unless we had drawn out a preoperative plan, and that was stuck on the operating theater wall. And that makes you look at the x-rays in detail, makes you spend time with the x-rays, understand how much you want to achieve with the acetabular component. So planning, knowing where to put the socket, identifying the medial wall, as has been mentioned as well. So identify the fat on the medial wall, and that's a good landmark that you've got right down to the medial side of the acetabulum. So planning and identification of bony landmarks for me is key to preventing problems in that area.
Thank you, Sanjeev. And I think both of you have pointed out a very important landmark, which is the fat pad on the medial wall. And the fact that whether you're using cemented or uncemented makes a difference to how deep you ream. Vijay, coming on to you, if you can address this issue, and then I know you've got some illustrative cases of femoral fractures intraoperative. So Vijay, we've already introduced, and he's very kindly joining us from Chennai. Over to you, Vijay.
Thanks for having me, Keshav. Am I visible? Yeah. So addressing this problem of socket reaming, the polygonal fat pad is the most important clue that we all emphasized. Another thing that you do with the templating is that you find out at the supralateral margin how much is your cup is going to underhang or overhang. Now, if your cup is not going to overhang on the template, and you find that it is doing so during the surgery, that means you're doing something wrong. You've got to revisit as to your orientation of the cup rather than ream more to get that. So that would be the other tip that I would add. But the polygonal fat pad is really the key point where you want to leave the cup at the level of the true flow. rarely in dysplastics, in Pro 2, Pro 3, may have to medialize a little more, but never beyond the inner table, never beyond that. I'd go sometimes in Pro 2, Pro 3, slightly a couple of millimeters more to get superior cover. So that would be my take on that.
Thank you. Would you carry on with your femoral splitting case, please, in your
I'm
presentation?
not sure it's a femoral splitting, but right, okay. So we'll show you some of the complications that we had in our primary hips. So this is the first one. So this is the 35-year-old patient. She had a road traffic accident in 2008. And you can see that she had a segmental fracture, so which was treated with the elsewhere. I mean, I'm not the surgeon now. So with the supracondylar nail, and then immediately after they did this surgery, they found out they had missed the fracture neck of femur. So another learning point in these cases, especially segmental fractures, you can miss these neck of femur fractures. So that was treated independently with screws, and you can see a fibular graft there. So she did okay for about a year or so, and then I can see that. That's how she presented to me. It's 18 months since injury. The fracture is almost united, but she's got a very painful hip. And here you can see that she's got avian, post-collapse avian. She's got a fibular graft, the screws. So the obvious thing to do here would be hip arthroplasty. So we decided to, the distal femur fracture was very united or not. So we had, plate, etc. To deal with it, should we see something else perioperatively. So we proceeded to do this THR just like a routine case. So probably lack of preoperative planning. And you can see the fibular graft in the neck. And I was happy with the post-op x-rays, although perioperatively, we find due to the fibular graft, we had to really bang it hard to get the stem inside. And then I think 4 weeks after the surgery, she presented again, and you can see the stem has fully subsided. Now, this is back in 2009, where the ASR was very popular. So this is actually an ASR cup, and you can see the stem has subsided significantly. So the moral of the story is that whenever you have implants, even if you don't have a fibular graft, there can be significant remodeling around implants, screws, neck of femur fractures, etc. So you must have some instruments to deal with it. You think you can overcome that by force, by just hitting your rasp hard, you are in for trouble. And this is a lesson that we learned. And from then on, anything else that we have in the femoral neck, whether it is all implants, some kind of remodeling, implants that have been removed, we will have a Midas Rex high-speed bar to deal with it. And this was, of course, revised to a distal fitting process. Okay. She continues to do well, by the way. Although the ASR, I've used the cobalt chrome solution stem probably because of that. She continues to do well. So the important thing about avoiding fractures is finding at-risk situations. So when you have some kind of protrusio and you have a constriction of the introitus, you've got to be extremely careful. And this is sometimes we miss out. It's what we call the bolted hip. So he has some kind of a proximal femoral nail, and the nail is sticking into the socket. You don't realize it. You have the dislocation is going to be a problem. And as I said earlier, the implants is always a problem. So the golden rule is you leave the implant in situ and you do a dislocation first, and then you take out the implants. The exception being a bolted hip. By do the reverse, you remove the implant and then you dislocate the hip.
So Vijay, can I cut in here for quickly? I saw your first case, and your first implant you used was a collarless one, and then the second one was collared. Do you have any preference these days about using a collared or collarless femoral stem when you're doing an uncemented one?
Yes, the dominant stem that I use is the Korai stem, and we have moved on to a collared Korai from a non-collared version. But having said that, I've not had any problems with the non-collared one. But the arthro group, told me that's a better way of doing it, so I moved on to a collared one.
So my experience is when I was using Korai non-collared, I used to probably have a femoral split once a year, maybe twice at times. But since I moved on to a collared version, that's a thing of the past. And then you don't have to worry about it subsiding at all, as long as you've got a decent fit. So yes, from my point of view, I think that's a good step forward.
I agree with that, Keshav, yeah.
Yeah. Sanjeev, what do you think of collared versus collarless? Because I know you are collarless, I suspect.
I am, and I used to be a fairly regular Corai user, but I had slight concerns about putting a fully coated stem, especially in younger people. So since I've moved to a proximally coated stem, I use a collarless stem. I rely on the metaphyseal fixation, and for me that works fairly well. Femoral split, very rare in my practice, not that I can remember in the last couple of years.
So Jonathan, you are a cemented guy as far as I can see. You are obviously an Exeter adherent, so you don't get femoral splits, I suspect.
Well, you know, when you use cement, you don't have to go for that breast fit feel,
Yes.
and so it is perhaps easier for me to stop with a smaller rasp than it would be if I was going for breast fit. And the other thing is that with the cement, because you're putting a prosthesis into cement, you've got control over how deep you put the stem. So I've got control over the leg length without having to seat the stem, you know, after it's already made contact. So yeah, I don't have that much experience with intraoperative femoral fractures, I think.
So Vijay, if you were to have an intraoperative split, how are you going to manage it for the benefit of our trainees?
I'll just show that in a couple of slides. Is that okay, Keshav?
Yes.
Better with the pictures on, yeah. So this is the one with the bolted hip. You can see that. Interestingly, I was doing a live demo surgery with an audience of nearly 1,000 surgeons, and I was a surgeon, and I did talk about all this. And then when I dislocated it, then we had a distal femoral fracture. So all the delegates saw it live of how we manage a perioperative fracture. We put a plate on it at the same time. So be very careful when you have an implant protruding into the socket. You have to remove the implant. This is the exception to the rule that you keep the implant before dislocation. So she continued to do well. This is an hemiarthroplasty, not really a primer hip, but the way of doing this would be you dislocate the stem rather than the cup. We find it very commonly in our population here. These type of things where it really protrudes your type. The only way of handling is you do a ETO and remove the stem rather than the cup. So don't use excessive force. The directional sizing of your rasping is very important. Varus positioning must be avoided in a non-simplet stem. You will cause calcar cracks if you are going to rasp your femoid and a varus. So as Jonathan mentioned, if your size during preparation is much smaller than the templated size, it's very likely that you're in varus. So you retrace your steps, find out what's going wrong, and do that. So 2 types of fractures. The question that you asked, Keshav, one is a calcar split, but you must make sure it's only a calcar split where you just do a wiring and you get away with it. Usually nothing happens. The other one is a fracture that goes below the lesser trochanter, like the one that I showed in my first case. It's very important that this is not a calcar crack. Many people think, just wiring it will do. It will not do. You have to put a distal fitting stem. I repeat again, you have to. Luckily, we have a lot of revision stems in our OR always, so we're able to handle that. But it's absolutely imperative that there's a wiring will not work in this type of fracture. Very typically, an iatrogenic fracture is a fracture on the medial side. The lesser trochanter has the middle part of it. It breaks down the lesser trochanter like that. This would need a long fitting stem. The approaches you are non-familiar with, high risk, like now the anterior approach if you want. Females, age, osteopenia, risk factors, previous implants, bone grafts, etc. So all these things that I said, you got to avoid all these things. So preventable problem, identify risk factors, adequate exposure, don't do new approaches if you're not familiar with it. High index of suspicion is the key thing for fractures. So identify it and treat it as required, and you must be prepared to deal with intra fractures. Thanks, Keshav.
So I think that nicely brings on to a big problem in total hip replacements, which is acetabular fractures. And to tell us more about it is Ananda Nanu, who's joining us over the phone, I believe. Ananda, I hope you're there.
Yeah, I'm here. And you've asked me to turn on my video, so I have.
Brilliant.
Okay, we've had a few technical glitches. I've sent the presentation. I'm not sure that Clockwork Medical have actually got it. But I think the big problem with femoral intraoperative fractures is usually one-off approach. Either you make your incision too small for your degree of competence, or you place it more anteriorly, or you place it more posteriorly. And, I think you've got to be aware that you can do both cemented and uncemented. And if you have a calca crack, and even if it goes under the lesser troch, if you can recreate an intact tube, there's no reason why you can't switch to a cemented prosthesis. Anyway, that's something in the past. So the big issue you get is, I'm just going to show you this slide. Can you see this picture?
Yeah, we can see a pelvis with a right total hip replacement.
Correct. And you look at the right total hip replacement, it's an Exeter Trident. It's not done particularly well. It's in varus, and you can see a bit of calcification around the tip of the trochanter. It tells you that it's most probably done through a hard-hinge approach. So unfortunately, or fortunately, this person was extremely happy with the results on the right. So he's 72, and the surgeon who is performing his other side. So this is a case that is about 5 weeks old. It happened in our unit, and a pretty experienced consultant of 8 years standing was performing this surgery. And he was performing a double table. So he was doing joints in 2 theaters, switching between the two with a surgical assistant. So he decides to, despite this person's age, to go for a hybrid, a cemented Exeter with a Trident cup. And can you move the slide one further forward, please? So during the procedure, he finds that the cup is seated deeply. And anyway, to cut a long story short, because time is short, he has an acetabular fracture. So what I want you to think about is, you can have your instruments ready to fix a femoral fracture, either with cabling or with plating or switching your prosthesis. But acetabular fractures are probably something, especially if you have one or both columns gone, where people are pretty uncomfortable proceeding straight away to another level of surgical intervention. And I just thought I'd ask my fellow panelists or any member of the audience, including you, Keshav, what would you do in this situation?
So, Vijay, let's start with you.
So I'm not able to see the picture very well, but I suspect there's an intra fracture of the acetabulum. Yeah. So the way we look at acetabular fractures intra is that if it's just a wall fracture and it doesn't compromise the stability, we're happy to do a non-cemented. We never cement our sockets, so we're happy to do a non-cemented socket and put screws inside. But if there is a columnar disruption, it's absolutely important that we will plate that column, especially the posterior column, and then we proceed with the non-cemented cup. That would be our strategy to manage if this, what was shown was a posterior wall or a column fracture, although I couldn't see that very well.
I think if you move one slide further, you might get a clearer idea of the...
Okay, we are one slide down. Vijay, you can see that?
Yes. So now there is also a medial wall which doesn't worry me, but perhaps we need to look for really expose the column as you do for your acetabular fracture. See whether the column is intact. If the column is intact, quite happy to proceed with just a standard cup and screws. If the column is not intact, you need to plate that column before then, otherwise you're bound to fail.
Okay, so Jonathan, your views on this?
Thanks. Like Vijay, I was struggling to see what the actual injury is in this case. I think the principles that Vijay's just talked about are absolutely spot on in terms of the intact nature of the column and the isolated medial wall. Ananda, can I ask, what was the nature of the injury there?
I've actually shown you the CT, and so you gather that obviously the patient was backed and the surgeon wasn't comfortable because it was clearly the column was gone, the quadrilateral plate was gone, and he wasn't sure about the extent of the injury. And I think he wisely, and the message here really is that there are periprosthetic fractures and there are periprosthetic fractures. And obviously the easiest thing is not to get into that situation in the first place. But having got there, you've got to know when to bail out. And you've got to know, because if you need to plate the anterior column and plate the posterior column, or you need to span across, or you've got a significant pelvic discontinuity, these are different degrees of problems that will require skills that not every arthroplasty surgeon, I mean, here you're talking to Vijay and yourself, both of you have an immense amount of experience, but the average arthroplasty surgeon in the United Kingdom probably would not be comfortable going into the ilioinguinal or stopper or indeed posterior column that exits high up in the sciatic notch. And so I think the safe thing to do is obviously pack it, close it, image it, and get help. And that was essentially the message. The solution is fairly straightforward once, you know, as both you and Vijay have said, if you just move the slides on. But I think a periprosthetic fracture of the acetabulum is a different kettle of fish as compared to the femoral one, because most people are comfortable dealing with a femoral periprosthetic fracture, but they are not comfortable dealing with an acetabular fracture. And if it's a simple wall fracture, it doesn't really matter. But if it's a column fracture or both columns or an associated both columns, then I think you're in deep trouble and you do need to ask for help. So that was my message, really.
It's interesting, isn't it? Because that's exactly why I said, what is the exact injury here? Because before you speak or before you act, you've got to know what you're dealing with. And that's exactly the message that you were talking about, isn't it, really?
That's right. That's right.
So I suppose the take-home message here is do not get into that situation. The acetabular fractures are very, very difficult kettle of fish. So if I move on, Ananda, do you have any other case you're going to show or share?
No, just the one. And I just wanted the opinion of the panel on. You see, there's such if you're cementing the hip, there is, that's why GIRFT in this country has had such an impact, is that the average surgeon, and 50% of us are average, it's easier to get away with cemented both sides hip. But you do need to be pretty meticulous and pretty outstanding to get the same results with an uncemented both sides. And I speak as somebody who's done only uncemented until maybe 4 or 5 years ago. And as one of the proponents of GIRFT, I've now switched, mainly because I can't tell people to do something that I'm not doing myself, not from conviction. I think the difference here is it's a question of line to line. And when you switch prostheses from one to the other, you need to recognize that the reamers, if they are labeled 47 or 48 or 56 or 57, they are sometimes undersized in with some companies. So when you think you're reaming to a 54, you're actually reaming to a 53 because they've built in a 1 millimeter difference for you to get a good press fit. And in some companies, it is actually line to line. So when you say that I always under ream 1, or I always under ream 2, or I always ream line to line, it depends on the prosthesis you're using. And the problem arises when you shift from hemispherical to elliptical, or you shift from one make to the other, and you don't recognize the difference between the sizing of your reamers and your actual implant. So that was essentially the other message I wanted to give. It's one that you see quite frequently. We dealt with the pelvic and acetabular work in the north of England for many, many years. And this was one of the common things we saw when there was a vogue for uncemented cups. So that's all. The 2 points that I thought are important, because it's an experienced audience here, is to say that if you do get into trouble, there's no shame asking for help in the acetabulum.
Thank you, Ananda. Another very quick point for our trainees from my perspective is eccentric reaming, which I've seen a number of trainees do. Eccentric reaming to the extent that they are blowing out of the anterior column. And then you end up in a much worse situation because you have lost your bone stock as well. So you have nothing actually to plate back. So again, you have to have 360-degree exposure, absolutely, and you need to keep on checking over and over again as you ream between one reamer to the other. The next issue that a number of trainees have flagged up is the acetabular orientation and dislocation.
Sorry, Keshav, can I stop you there for a second?
Yeah.
And can I just ask the panelists, why does the reamer always tend to ride up and anterior?
Okay, Jonathan.
You're right. You tend to ream off the anterior wall. And if you look at it's a design reamer problem, isn't it? And it does happen. And I think one of the things that you consciously need to do is to use your hand to pull the reamer down to stay on the towel and to move it posteriorly, because it does tend to walk anteriorly. And these are tips that I'm sure that the panelists do subconsciously, but it's not something that you tend to tell people that you selectively ream anteriorly. And I think a lot of people who are training have not actually physically been told this until they find out for themselves the hard way. What do you think, Vijay and Jonathan?
Well, I think you're absolutely right.
I don't know why it goes. Sorry, Jonathan. Yeah. So the one tip that I have is the fat pad. You find the true floor. So that of course tells you the depth of your reaming. It also is a good landmark for you anteroposteriorly. So if you are if the reaming and you are that the palmar fat pad was very posterior, then your reaming is very anterior, and so the other way as well. So that area, the teardrop as we call it, must be the center of your reaming. That's the thing that you don't stray anteriorly or posteriorly. The other tip about this thing is no harm in using a trial. Trial I find is very useful because sometimes the reamer can be blunt, or it can be a new reamer, can be very sharp. So this line-to-line reaming or 1 mm under reaming may not work in all cases. It's always better to use a trial, but you must know what is the differential between the trial and the real cup. For example, the Striker PSL, the differential is 1.7, is probably one of the highest. The Pinnacle would be 0.6. So unless you know that, you wouldn't be able to do that. So once you know that, I think it's a very safe thing to put a trial in and see that you got your good 3-point fixation before you bang your real cup. Jonathan, sorry, apologies. Check out.
No, not at all. So I'm looking forward to hearing Ananda's reasons why we go high and anterior, because I know that happens, and you're right. Instinctively, we know it happens, but I'm not absolutely sure I've really thought why we go anteriorly. There are some pathologies where that's more dangerous. In dysplastic hips, for instance, it's much easier to run out of bone quickly when you put the acetabulum down at the true floor, and that bone tends to run out most easily anteriorly. In the standard case, I think it's really important you know what the size of the reamer and the implant that you're going to likely put in, and again that starts with knowing what your head diameter is. And if you are finding you're using a reamer that's significantly bigger, like more than 4 millimeters bigger than your femoral head, you better know where you are and what you're doing with that, because that you're getting into danger points. But and Andy, you're absolutely right. We do hold the reamer posteriorly and down right on the towel. But what is the reason why we go high and anterior?
So if you take a reamer and you spin it, it spins clockwise. And if you look at the cutting flutes in it, it tends to walk anteriorly. And if you think about it, if you're reaming, say, for example, the left acetabulum, your right hand is on the reamer shaft and your left hand is on the gun. So when you're pressing here, with the torque of a clockwise movement, it tends to move anteriorly and it tends to walk through the bubbles on the cutting flutes. It tends to move anteriorly, and that's exactly the same on the other side as well. And it's one of the things that I always use the hand on the shaft to control, and the right hand is just squeezing the trigger.
Thank you, Ananda. We're running short of time, so I'm going to come to dislocation, and I'm going to ask Sanjeev, what is your take-home message that you can give to the trainees for cup orientation and prevention of dislocation?
Sure. I think we keep going back to the first message of planning. As was mentioned in the first talk, planning is crucial. For me, the rigor that the surgeon exercises in testing the stability of the hip will really set his outcomes. And the more honest you are with how much stable you've got a hip on the table, that will be the result of what you get after surgery. So when we do hips, well, certainly when I was trained how to do hips, there's a certain sort of ritual we go through in testing the stability. Not enough time to discuss it here, but I think that for me is the key. I have to be absolutely satisfied that I've got the offset and the length right, and there's no component impingement, no soft tissue impingement, and only then I'll start closing the hip.
Okay. So Ananda, would you put your version or your inclination in a certain way where you got a window of comfort to say, if I'm here, my cup will be not a dislocatable hip?
No, I think the planning is the key to all this. But when I'm looking at the acetabulum, I use the towel, and I think Dave Beveland has taught generations of surgeons this. So use the towel for your inferior mark. If there isn't any osteophyte, if there is any osteophyte, to identify the plane and take the osteophyte off. And I try and keep the anterior rim of my reamer about 1 millimeter behind the anterior, because I don't want the iliopsoas or the anterior structures to touch the anterior rim of the cup so they don't get groin pain. And if you keep the inferior part and your anterior part right, all the rest of it tends to follow, provided you don't ream eccentrically. And we've talked about holding the shaft inferior and posterior when reaming to avoid that. So those are the only tips that I have, because I think, except in a dysplastic acetabulum, and that's a completely different ballgame, it's actually quite simple. You just need to follow the normal anatomy, but first you have to delineate the normal anatomy and predict it based on your preoperative planning.
Thank you, Ananda. Jonathan, what precautions would you take, or how would you deal with a hip that is a leaky hip, maybe going on to superficial and then on to deep infection?
A wound that's leaking on the ward?
Well, yeah, what do you do intraoperative to prevent that from happening on the ward, and then all that rigmarole that happens after that?
Okay, so I think a prevention of leaky wounds starts preoperatively with knowing the patient. If they're on anticoagulants, making sure that those are stopped appropriately according to the indication, etc. If the patient's got a bleeding diathesis, it's about talking to a hematologist and working out what you can do to prevent hematoma formation. If the patient's got a mechanical heart valve, it's working out how you're going to manage the anticoagulants in the perioperative period. Intraoperatively, I think soft tissue handling is key. Meticulous hemostasis is key. I don't tend to use, I don't use drains. I haven't used drains for 20 odd years in either primary or revision. I don't think that they're going to help with the occurrence of leaky wounds. I think post-operatively, if you've got a wound that's leaking, do a risk assessment on the VTE risk, and if possible, stop chemical thromboprophylaxis and keep the mechanical going, but have a very low threshold. I personally have a very low threshold for going back to theatre and washing out a leaky wound, and in fact changing as many components as I possibly can.
Thank you, Jonathan. Last 30 seconds to Vijay. A tip to prevent sciatic nerve palsy.
Well, in complex cases, of course, we do identify the sciatic nerve, but otherwise you stay well away from the sciatic nerve. And I must say that it's very, very rare complication unless you do some major mistake. Complex cases, Crawford, etc., we do identify the sciatic nerve and we feel for the nerve and make sure you don't, leave it very tense. Otherwise, you stay out of the sciatic nerve.
Don't over-lengthen the leg, because that's a surefire way of getting sciatic palsy.
Absolutely, yeah.
So that's a great discussion. I hope you've enjoyed it. Thank you, Ananda, Vijay, Jonathan, Sanjeev, and Sheval. And we'll call this an end. Thank you so much.